Good evening, everybody. We have completed 25 webinars. Today is the 26th one. And this is a series which is held on every fourth Thursday of every month on behalf of the Indian Myeloma Academic Group. We have a journal club which is discussed in details by the presenter. And then we have, after the article has been presented, we will have comments from the national as well as the international expert on this topic. The journal club will be followed by a journal scan, and the article has already been sent to almost 3 weeks back. And we have entries which have completed, and that will be taken up by Dr. Sumit, who will actually declare the results of the Eagle Eye competition. That will shortly be followed by Dr. Nitin, who will actually do the online quiz for today. And then, of course, we will wind up by 6:30, and maybe Pankaj will have the last word at that point of time. So, without wasting any time, let's go on to the journal article first. The article for today is teclistamab, which is something that we are all looking forward to, a bispecific in relapsed refractory multiple myeloma. And the importance of this article is that it is not a trial, but it is real world data. This has been recently published in Blood Cancer Journal, and Urmi from Dinanath Mangeshkar Hospital, Pune, will do the presentation of the journal club, which will be followed by comments from Dr. Samir as the national expert and Dr. Rajshekhar Chakravarti as the external or the international expert. So over to all three of you.
Thank you, ma'am. Shall we straight dive into the presentation? So this was a multi-institutional real-world study, teclistamab in relapsed refractory multiple myeloma. Just a brief introduction on what is teclistamab. It is a T-cell redirecting bispecific antibody which targets a B-cell maturation antigen. It was approved in November 2022 by US FDA in relapsed refractory multiple myeloma. The mechanism of action is it has a dual target. One target is the BCMA on the myeloma cell, and the other target is the CD3 on the T cell. This teclistamab, which is a bispecific antibody, then brings the BCMA and the CD3 together. Then there is T cell activation, cytokine release, perforin granzymes, the downward spiraling, and then there is a myeloma cell death. Why do we need a real world study? Well, the objective of this study was basically to bridge the knowledge gap between the data which was present in the clinical trial studies and the real world. What happens is that in a clinical trial, there is not a very diverse cohort. Some patients are left out, maybe due to comorbidities, or they have potential for high toxicities due to the drug. So those patients do not get included, which who do receive the drug in the real world. And sometimes because of the prolonged screening period, patients who need an immediate treatment are also being left out. So to bridge the gap between these two cohorts, this study was carried out. The study was carried out in 5 US centers from January 2023 to August 2023. Relapsed multiple myeloma patients were included, those who had received at least one dose of teclistamab. At baseline, their demographics were documented. Disease was characterized in terms of a baseline bone marrow, a PET, and a FISH. The disease was further subclassified into whether it was a triple refractory, a penta-drug refractory, or a high risk. Triple refractory was the one which was refractory to a prior line of anti-CD38 antibodies, IMIDs, or proteasome inhibitors. Penta-refractory were daratumumab, bortezomib, carfilzomib, lenalidomide, and pomalidomide refractory. High-risk diseases were defined as the ones that had translocation 414, 1416, 1420, 1q21, and del17 deletion 17p on FISH. At the baseline, IVIG and blood counts were also documented. This was done at prior to starting the therapy and repeated at day 1 of every cycle or as per the institutional protocols. Hypogammaglobulinemia was defined as when IgG levels were less than or equal to 400, neutropenia is less than or equal to 1000, and lymphopenia was also as less than or equal to 1000. The drug was administered in a step up fashion. First 0.06 milligrams per kg was given, followed by zero point 0.3 milligrams per kg, followed by 1.5 milligrams per kg. This was given either on day 1, day 4, day 7, or day 1, day 3, day 5, as per the institutional policy, which was then followed by 1.5 milligrams per kg weekly. CRS and ICANS were also observed for and graded as per standard guidelines. Management was carried out as per the choice of the institution. Infection was documented, its prevention was carried out, IVIG was also supplemented with, and the treatment was given as per the institutional guidelines. Statistical analysis was done in terms of ORR, which was defined as proportion of patients achieving a partial remission, a VGPR, a complete remission at any time. Time to best response was documented, which was defined as from the start of treatment to the best achieved response. This was all done through Kaplan-Meier estimator for overall survival.
Because when we discussed with the statistician, they said that it's very hard to comment on median PFS when the median follow-up is so short. And when we look at the Kaplan-Meier curves, we will see that the beyond like 6 months, the number of patients at risk is very, very low. So the estimates are very unreliable beyond 6 months. At this ASH, we presented the same data set. We will present a poster on the same data set with a median follow-up of roughly about 9 months. And that has a little bit more mature data on the PFS. But I just wanted to point that out.
Sure. So within the subgroups, the ones with high risk, like the factors which could predict response to the therapy. They studied age, high-risk disease, EMD response, prior lines of therapy, or prior BCM exposure. None of them were contributing to prediction to the therapy. In terms of safety, cytokine release syndrome was found in about 56% of admitted patients. Out of them, 93% had grade 1 or 2. Grade 3 was found in 1 and grade 4 was found in 4 patients. ICANS were found in 11% of those patients. Grade 3 were found in 5 and grade 5 were found in 1. One-third of those patients received tocilizumab, and systemic steroids were given to about 17% of patients. Infections, almost all received HSV and VZV prophylaxis. PCP was given to 57% of patients. Antimicrobials were given to 12%. Antifungals were given to 14%. And primary IVIG prophylaxis was given to 43% of patients. So the preventive measures were also a little heterogeneous in this study. They do mention that this is one of the factors. We'll cover that during the discussion also. There were total 78 infections which were documented in 44 patients. Grade 3 or more were in 26% of patients. Cumulative risk at 3 months was close to 39%, and at 6 months it was about 30%. For grade 3, at 3 months it was 25%, and at 6 months it was 31%. Median time of documentation of infection was 60 days from the start of the treatment. Bacterial was the commonest found, which was 48%, followed by viral, followed by fungal. The predictors of infection, none were found except IVIG, and as in it had a preventive role to play, and prior infection of teclistamab made them more prone to get infections. IVIG prophylaxis was also, this was the first study to give primary IVIG prophylaxis. They studied the cumulative incidence with and without IVIG. At 3 months with IVIG, the cumulative incidence was 35% and without was 44%. At 6 months, it was 35% and without IVIG was 54%. Out of these, grade 3 at 3 months, grade 3 or more at 3 months with IVIG was significantly lower at 17% as compared to 31% without IVIG. And at 6 months was again lower at 17% as compared to without IVIG of 43%. So this is a table showing the comparison between real world and the Majestic 1 study population. The important ones to highlight here are the CRS and the ICANS. The CRS percentage in the Majestic 1 trial was up to only 0.6%. Here, all grades or more than or equal to grade 3 were about 3.6% in the real world data. A lot more ICANS are seen in the real world, about 4 to 5% as compared to again 0.6% in the Majestic 1. Right. So coming to the discussion, 3 major points were discussed and were documented at the end of this study. One was there is a rapid achievement of deep response. There was a efficacy maintained in the heavily pre-treated and high-risk patients. The response and the efficacy was comparable. There was a comparable VGPR or more rates to the Majestic 1 and Magnetism 3 trials. There was no impact on response rate in patients with prior exposure to a BCMA targeted therapy. Real world ICANS and CRS were higher as compared to the trials. Like we discussed earlier, Majestic 1 had only 0.6 each, Magnetism had 0% each. Real world has had 4.5 and 3.6% each. One of the factors contributing to a higher ICANS and CRS in the real world is possibly also because the patient selection. There was a high disease burden at the onset of the trial, which contributed in the real world. And IVIG prophylaxis to reduce infection. It was found that it was associated with significantly low
We have lost her voice.
Yeah, and we can't even move the slides.
I think she has reasonably discussed the things. So, Samir, you can start with the. Okay, she's
Yeah,
there.
no, she's back.
Yeah, sorry, just some glitch. Right. So,
Kindly share your slides. Slides are not
is it
visible.
being shared now? Is everybody
No,
able to see it?
not yet.
Oh, okay. It is.
Maybe you stop sharing and share again or something.
Yeah.
Yeah.
Visible?
Yes.
Yeah.
Yes.
Okay. Great.
Previous slide. Go to the previous slide.
The discussion slide.
Yeah. Yeah. Yeah.
Right. So, the other important finding was that the PCP prophylaxis should be given to all BCMA and bispecific antibodies when they are used, because without that prophylaxis, almost all had that infection documented. The conclusions were that this was a diverse institutional cohort with a high disease burden. But the shortcomings were that it was a short follow-up. There was a heterogeneous infection prophylaxis given. Also, because it was a study where the bone marrows and the PETs were not done on a regular basis, were done documented only at the start. Possibly that's why the CR which was achieved in the real world data was also lower, up to 20%. However, the strength of the study was also that, I mean, the encouraging things that we found from this study was that there is a rapid achievement of a deep response at the cost of higher real world ICANS and CRS, and IVIG prophylaxis helps. Okay, thank you.
So thanks, Urmi. That was a nice, clear presentation of real-world data, something I think everybody is looking to. And we'll have comments from Dr. Samir now.
Hi. Good evening. So, thanks, Umi, for the good presentation. So, this is like is a very, I would say this is a very good study. Real world data is always complementary to the to the original study. So, this is one of those. But my question to Dr. Rajshekar was again, why was it done so early? With only 3.5 months of follow-up. You know, why couldn't it be done? I mean, the 9 months would be much more interesting. We'll be looking forward to hearing about that in ASH. But with 3.5, you're probably going to assess only the initial toxicity, etc., and how soon the responses happen. But I'm sure you would want a longer follow-up.
Yes, absolutely. It was, at that time, there was the real world data coming out, and several groups were studying that. And I think there was overall a rush to like get the initial data out. But I totally agree
Okay.
with you. 3.5 months, all we can comment on is the response rate because the responses are very rapid. So I think 3.5 months is enough to comment on the VGPR rate, but it's not enough to comment on the cumulative rate of infection and, of course, the PFS and OS. So I can give you a brief update on the 9 month follow up that will be a poster at
Yes.
ASH this year. So at about nine month follow up, we are seeing the median PFS was about 12 months. So which is roughly similar to what we saw in the trial, and the cumulative risk of infection. So it was it was high, but when we look by IVIG again, we see the same trend that patients who got primary IVIG prophylaxis, they had a lower risk of grade 3 or higher infection. It did not really affect too much the all grade infection, but the grade 3 or higher infection was lower in patients who got IVIG. So the cumulative risk at 6 months of grade 3 or higher infection was about 34% in all comers. And those who got IVIG was, if I remember correctly, roughly about 20% or so. So, despite a very sick population, it was lower. Yeah, I think those are the main things. One important thing is the PCP prophylaxis. So patients who develop PCP in our cohort, none of them were actually receiving prophylaxis. Those who were receiving prophylaxis, they did not develop PCP, and the risk of PCP was about 3 to 6% in the clinical trials because they did not use prophylaxis. So it's an important thing to remember, I think, to use PCP prophylaxis in these patients.
So the other point that I wanted to mention is that one is that one thing that struck me is in the Majestic, there was a weekly dosing for the first 6 months, etc. And here it's mentioned that you're doing it as per physician's discretion, and I agree because from whatever initial experience we've seen where the responses are sometimes very steep in the first 4 weeks itself, and then you really don't know why you're giving it weekly. So, what is the general physician's discretion? How much do you cut down the doses? Do you give it bi-weekly? Do you straight away jump to monthly doses? How do you do it?
Yeah, so right now, it varies from institution to institution, but most places in US are doing it initially weekly, and then as soon as they do a VGPR, which is typically by the end of first month or second month, we are going to every 2 weeks, and starting 6 months, we are going to once a month or monthly. However, some of the clinical trials of teclistamab, some of the newer trials, they're actually going to Q monthly, even starting cycle 2, starting second month.
Yeah.
So I think that data is not out yet, but and in the real world, in many patients, I've actually stopped at 6 months completely because they are MRD negative CR, and if they're older and frail, I'm worried about infection. I stop at 6 months, and we also have another paper, looking at those kind of patients in trial who we stopped for some reason because of toxicity, and the relapse risk is very low at a median follow-up of about 1.5 years. Only about 4 out of 20 some patients had relapsed. So it's very sustained remission despite stopping it after 6 months.
Yeah. I just wanted to say on that note, I would like to also, hear your thoughts about this concept of T cell exhaustion. And how soon does it typically develop? And like if you stretch it to beyond 2 years, does it really work when there's so much of T cell exhaustion, or how is it? Or would what you said, if you once you have an MRD negative state, whether giving a break and then restarting, would that be more useful than giving it continuously?
Yeah, that's the main concern that, T cell exhaustion will definitely happen if you keep giving it longer. I don't think there is any clinical data yet as to when exactly that happens, but the thought is that approximately after 6 months, the T cell exhaustion can set in. So there is actually a clinical trial currently being done by UPenn, and we are also participating in it. It's called as Limitech trial. So where everybody starts teclistamab standard of care, and then at 6 months, if their VGPR or better, and we are also checking MRD, but if their VGPR or better, then at 6 months we stop, and then we monitor them monthly. And if they have any biochemical relapse, then we restart at that point. So far they have enrolled about 19 or 20 patients, and the follow-up is still early, but to my knowledge, nobody has relapsed yet. So that will be the first prospective study looking at that. And we are also checking monthly CD4, CD8 level and CD19 level to look at immune reconstitution after stopping the teclistamab. So to my knowledge, that's the only study which is, of course, pharma, they don't want to do de-escalation studies because they want to give it as long as possible. So it's hard to get funding for those kind of studies.
Yeah, but I think that's very useful knowledge from you. Thanks for telling us about this. All right, then. Um, uh, so yeah, I could also note that um, there were three patients who underwent allogeneic. Allogeneic transplant is a contraindication for any of the clinical trials nowadays. So that those also were included. There were more black patients, significantly more blacks, yeah, in the real world, and those patients always apparently they tend to do much worse than the Hispanics and whites. So my question to you was regarding the penta. So we always classify, when we are going on to a either a CAR T or a bispecific antibody trial, we always talk about triple and penta refractory disease, right? So was that specifically analyzed, since we are kind of classifying them that way? Was there specifically was the analysis done in those who were triple refractory versus those who were penta refractory, and was there any difference between these? I mean, somebody had received cofazamab and pomalidomide and then gone on to teclistamab. Did they fare worse than the ones who were only triple?
No, so overall, with this limited follow-up, the response rates were no different in triple class refractory versus non-triple class, or penta refractory versus non-penta refractory. I think the question is, will the PFS be different? And I think for that, we need longer follow-up. But the response rate was the same, in those patients.
All, yeah. And the most important thing that I wanted to ask you was regarding the prior BCMA exposed patients. That is, so traditionally, from what I understand, if you're prior BCMA exposed, either it's an ADC or it's a bispecific or a CAR T, you generally go on to a GPRC5D. That's been the general trend across in the US, is from what I hear. So here you have a good number of patients who had actually had received a BCMA first, and apparently the prior lines of treatment did not affect this cohort as well. So can you expand on that a little bit? Because from what we understand, of course, the data has never been there so far. There were very limited number of patients who've been studied on the trials. That C cohort of the Tech9 study, of the Majestic study. So can you just expand a little bit on that and tell us what should we derive from this? Would it mean that you can actually do a CAR T and subsequently another bispecific BCMA directed bispecific should be the standard of care, or how should it be? Especially
So,
considering the poor quality of life that patients have with with the talquetamab because of the dysgeusia.
yeah, yeah, no. So for this, this study was done actually at a time when talquetamab was not approved in the US. So that's why, we did not have
Okay.
talquetamab at that time. It was
Okay,
approved more
okay, okay.
recently, right? So basically, for most of the patients in this study who had prior BCMA, they were either BCMA CAR T. So, they got BCMA CAR T and they relapsed, let's say 1, 2 years later. So at that time, they're relapsing on observation, not on any treatment. So we felt comfortable going to teclistamab, or those who got Blenrep, belantamab mafodotin, some of them, and those, we know belantamab mafodotin is as low efficacy. So, we felt comfortable using, it's a completely different mechanism of action, teclistamab. Very few patients in this study actually got a bispecific after bispecific. It was mostly either CAR T or belantamab. Now, having said that, in this study, those who got prior CAR-T, we did not actually see any difference in response rates to patients who got teclistamab with prior CAR-T versus no prior BCMA CAR-T. The question again is that whether the PFS will be different. I think that remains to be seen. And right now in the US, our practice is that if somebody has gotten BCMA before, we use GPRC5D next. However, if they have gotten BCMA CAR T before and if they're relapsing, let's say 2, 3 years after a BCMA CAR T, in that case, I would feel comfortable to use teclistamab again. But if they're relapsing like within 3 months after BCMA CAR T, then probably I will go to talquetamab instead of teclistamab. So it depends on how long, like how far away they are from a BCMA directed therapy. And of course, if they're relapsing after a BCMA bispecific, then I would like to go to either a GPRC5D CAR T or a GPRC5D bispecific.
Thank you. All right. So, yeah, it was also mentioned in the discussion that there are two studies going on with CAR-T followed by bispecific. So, can you elaborate a little bit on those? What exactly is being done in those studies?
Yeah, so CAR-T there is one report that was actually already presented, I think, in Blood a few months ago. With it had limited follow-up again, so we can't commit too much on the PFS, but the response rates were actually pretty good. The VGPR or better rate was comparable to what we would see with teclistamab without prior CAR-T. But again, the question is, I think, mainly the duration, because recently, even with the real-world CAR-T studies, it was shown that those who had like an interval of more than 9 months between prior BCMA directed therapy and BCMA CAR-T, they had a better PFS, compared to those who had an interval of less than 9 months. Probably because those who had an interval of less than 9 months, they are probably very, very aggressively progressing, and they are just going to do worse, no matter what. Whereas those who were able to get such a long remission, they have a more indolent biology. There are, several single arm studies going on with looking at, with prior CAR-T. But I think most of them so far have only reported the response rate, not so much the PFS or duration of response. I think that we need to see with longer follow-up.
And the last question from me is going to be about this concept of the lines of treatment in any clinical trial. There's a move to abolish the lines of treatment and go on to the class of the drugs, the number of drugs that the patient is refractory. If you received 4 drugs as induction and you're refractory to it, you are jolly well triple refractory and you can go on to the trial. There was a move to abolish this particular 4 lines, 3 lines, 2 lines of treatment, etc. Because in the clinical trials currently also you have to have those 3 lines or 4 lines. If you're less or more than that, the patient is genuinely needs the drug, and you're not able to put them just because lines of treatment. So you have, of course, real world studies really are important over here. They'll address the question. But do you think the lines of treatment is still important, or should it be abolished?
So yeah, I totally agree that if they're refractory to certain drugs, I think that should be the most important. But the problem in the US is because in FDA is still approving therapies based on lines of treatment. Sometimes insurance will not approve if we try to use it in earlier lines. But I agree that there was a study actually done by University of Alabama group where they showed that the refractoriness to the treatment matters more than lines of treatment. So for example, patients who had 3 prior lines of treatment but were not penta-refractory, they actually did pretty well, irrespective of having a longer lines of treatment. So I think that we have the data, but it just depends on when FDA or EMA will agree to that. So far, they still they're still persisting on lines of therapy.
Thank you. Anybody else has any?
Yeah. Hi, Raj. Good to see
Hi,
you.
see you.
And I think we are going to miss you at the Kolkata conference.
Yeah, unfortunately, because of some personal situation, I had to postpone the trip, to later. So sorry about that.
So maybe, sometimes that. So I just have some couple of questions. One is about, after this real world study, have you started doing routine IVIG prophylaxis to all your patients? And what is the dose and frequency? And how long do you give IVIG?
So we have been doing it as long as the insurance is covering it, because sometimes insurance will not cover and that it's very expensive, so we cannot do it. But we are typically doing it starting the end of cycle 1. So that's when most patients will drop the IgG to less than 400. So we are doing primary prophylaxis. We are not waiting to have like the first infection. So around the end of cycle 1, because by that time, patients who are not responding, we already know by the end of cycle one, and they will go on to a different treatment. But if they're responding, if the IgG is less than 400, then we are starting it. And there are many different formulations. The one that we use at our hospital is the Gamma Guard, and we typically, if I remember correctly, we use 400 milligram, I think. I can tell you the exact dose. I have to look up my hospital protocol. So it's Q4 weekly. So we do it every 4 weeks. We start at the end of first cycle one, and we typically continue until the IgG goes up. So in real world, we're actually stopping teclistamab in many patients at 6 months, 8 months. Once they are an MRD negative CR. But what we are seeing is that even after stopping, I have patients who are up to 1 year, they are still needing IVIG. Like as soon as I stop it, the IgG drops to double digits. But typically at the 1 year mark, at 1.5 year mark, at that point, some patients we are seeing they're slowly recovering their IgG level. At that point, I worry that are they going to relapse? But many patients actually are not relapsing. Their IgG level is coming up and to 600, 700, not normal, but slightly more than 400, but they are still not relapsing, but they're not needing IVIG anymore. But up to a year, they're still needing IVIG even after stopping.
Okay, and there are studies coming up where they're combining the anti-myeloma drugs with teclistamab. Although I feel teclistamab alone is
Yeah.
highly active. I would say highly active. And I just want to share one experience: a patient who had undergone a BCMA CAR T in Israel did not work, and within a month his disease was coming back, and we gave Teclista, and after 4 dosages he's not requiring anything, he's doing well. So this is when we are talking about whether the after BCMA CAR T, whether the Teclista map will work or not. At least in my one of my patient, it has worked. So what about the combination of therapy, Teclista map with the daratumumab and bortezomib or other drugs? Can you just explain those combinations?
Yeah, so right now, as you know, all the companies are doing trials on combination. So, with daratumumab and carfilzomib, the main concern that I have, especially with the daratumumab combination, is the infection. Because even though there are very small number of patients, like 30, 32 patients, which have been presented in ASH the past couple of years, in all of those patients, there have been about 4 or 5% risk of infection-related deaths. And those are the patients who are very, very cherry-picked, right? Like really going on phase one trials, so they have to be very healthy and and so you can imagine in the real world it might be higher. And recently, I think Dr. Vincent tweeted a few days ago that we should be cautious about teclistamab and dara combination in the real world, outside of trial. So in the real world, we are definitely not using it. Definitely, although in US, I mean, we can use it. Probably insurance might approve its later line, but we are not using it. In clinical trial, we are using it. I mean, I have used in a couple of patients the Regeneron product with dara. So far, those are very, heavily selected patients, and, I'm using IVIG. So far they're doing well. But in those patients, I will definitely, if they're an MRD negative CR, I will stop at 6 months. Definitely not continue like beyond that. But I agree that there is, we need really a randomized trial of teclistamab alone versus teclistamab plus combination to see if the combination is even adding anything, to single agent.
And I was hoping, Samir, you could share your experience of using Teclista map, just brief for the benefit of the audience.
So all over India, 50 patients have been dosed so far, from what I hear from J&J. 50 patients. It's been just a few months since it's been launched, and I have used it in 6 or 7 patients. I think teclistamab, and the response, or everybody has responded extremely well. The most of the patients have responded within 4 weeks, and the 2 patients have had to have used tocilizumab out of these 6, but just for fever, which was escalating, and that's about it. And IVIG prophylaxis we definitely give, for anybody who we give 400 milligram per kg every 4 weeks, and we just keep monitoring the IgG levels monthly. It's below 400 we give, and nobody's had a major infection so far. Even from my colleagues, from the first 20 patients that were there, I just spoken to the people who have used it, and nobody's had a major infection so far. It's a major concern for us because we have a very bad gram-negative infections, and even the 20% risk that you have in the US is like is a scare for us. Also, we are keenly looking at whether Cox tuberculosis, which is so common, could get reactivated. So we'll be keenly waiting and seeing whether any of that happens. Viral infections are there, nothing very, very serious, no CMV reactivation so far. So that's the present experience, although it's very short.
Yeah.
Yeah,
Thank you.
no, that's okay.
Yeah.
Thank
So
you.
Dr.
And also,
Sam,
I checked. Oh, yeah, sorry, go ahead.
go ahead.
No, I was saying I just checked the dose that we use at our hospital is the same, 400 milligram per kg Q4 weekly.
So I think there is a question from Sumit and from Uday, and if they finish with their questions, then I may ask one.
Ma'am, nahi ma'am, please, you can go ahead, ma'am. We'll ask you after you.
Okay, no, just that I have this patient who wants treatment and who is very sick and has chronic liver disease also. Will anyone advise me to try teclistamab in this patient?
So, I mean, teclistamab is not cleared by, at least to my knowledge, not cleared by the liver, or the kidney. So I would be okay with using it as long as, definitely that patient will be at a very high risk of infection if they have other comorbidities. So maybe for a short period of time with appropriate prophylaxis, and as soon as they get into a good remission, probably just stopping and, waiting and watching at that point.
For 1 month only. Yes, Sumit, go ahead.
After Uday sir, you can please go ahead first.
I have a quick query that the current dosing, which is prescribed by the company, is once a week dosing. And that leads to severe hypogammaglobulinemia. So, is it possible that we reduce the dosing? Though there are some studies going on, but at least at the end of CR, we make it maybe a fortnightly or a monthly dosing, or from upfront itself, if we can use a lower dosing, because the phase 1 data which actually looked at the dosing, it's not strong enough to exactly say that weekly dosing is much better than by a fortnightly or a monthly dosing. So your comments on that, please.
Yeah, so right now, I think they have already updated the package insert. So it's weekly only in the first month, but then it goes to every other week as soon as patients achieve a VGPR or better. And then after 6 months, it goes to, we can use it as monthly. So, in the first 4 weeks, at least I think still everybody is using weekly. But I think, even when we go to monthly, we don't see the IgG level going up. The IgG level still remains very low. So I don't know whether there is some data that, once you go to monthly, like after 6 months, the infection risk is slightly lower. Janssen had presented some data, but I am a little bit skeptical of the data because at that point, probably the bad players are already out, right? Those who were really sick, were destined to have a really bad infection. They might be already out of the trial. They had a bad infection and then they could not continue. So at that point, maybe you only have the really good, healthy people. So I think it's possible that when you go to every 4 weeks, the infection risk is lower, but I think the data is still very, very premature. I think linvoseltamab, the Regeneron product, they actually started like that. All of their trials are every 4 weeks, starting 6 months. And I think it would be interesting to see once they present the long-term follow-up data as to if their risk of infection is any lower than the others. But at least in the initial report, the JCO paper, it was the same as teclistamab. It wasn't any lower, in the first 12 months.
Yes, Sumit,
Thank
go
you,
ahead.
Sumit.
Mr. Am I audible?
Yes, yes.
So in continuation, Dr. Uday's question, the initial schedule of day 147 versus day 135, the latter is probably for reducing the hospitalization duration. Which one do you prefer, and do you see any difference in your routine practice while beginning?
Yeah, we usually nowadays use day 135 for most patients. And only on day 3, if they have a CRS, then in that case, day 7 after that. So we won't give on day 5. But we are trying to do day 135. And actually, most centers in the US are now doing outpatient completely because the risk of grade 3 or higher CRS is actually very, very low. Even if only in patients who are very old, frail, have a high tumor burden, then I think it makes sense to admit them. But other than that, doing outpatient is totally reasonable. We have had really no major I think the most important thing I'm worried about with teclistamab is infection. In contrast with CAR-T, where CRS or ICANS is of concern, but teclistamab, I think CRS ICANS is very minimal concern.
So
And
before,
apart from intro,
sorry, go ahead.
yes, ma'am.
Go ahead.
Apart from and routine before starting register, ma'am.
Sorry, your network, I couldn't hear the initial part of the question.
Do you routinely use vaccinations prior to giving teclistamab?
Oh, vaccinations. So typically, no, because most of the patients are going on teclistamab. Before that, also they are immunocompromised, right? They might be on Dara before that, or they might have gotten like maybe CAR T or something. So they are definitely no live vaccine. But sometimes the flu and the updated COVID vaccine that we would give, but definitely no live vaccine because also their myeloma might be active, so they are immunocompromised for that from that as well.
Dr. Rajshekhar, I would like to continue that question.
Yeah.
So, by the time a patient has reached teclistamab, he should have been vaccinated in the first place, right? When he's diagnosed itself, we've been vaccinating our patients. So, I mean, is there a case? I mean, of course, there would be suboptimal vaccinations, and we know that the titers of, say, for example, the herpes vaccine, the Shingrix vaccines, they don't tell us whether the protective immunity is there or not, and so there's no way of assessing whether they actually have protective immunity. So, is there any role of revaccinating them? You're saying there's no point in revaccinating them either before the teclistamab, is it?
So before teclistamab, if they are in a good overall, if their immune function is good, for example, if their myeloma has been in remission for a long time and they are not severely immunocompromised, I think you can consider it. But most patients at the point we're starting teclistamab, their myeloma is likely in relapse, right? That's why we are starting. So they might not respond to vaccines anyway. So at that point, we don't typically revaccinate at that point. We will, for example, after transplant, when they're in a remission, that is the time when we will sometime revaccinate, after auto transplant. But before teclistamab, we typically don't. In Mount Sinai, they did some studies looking at the COVID vaccine titers after teclistamab, and these patients actually do not generate any immune response because they're so immunocompromised. Whereas with talquetamab, it was slightly different. Their immune response was better than teclistamab.
Okay, so very interesting conversations. There is only one question in the question answer box which says check for CMV PCR for patients who are on teclistamab. Do you?
So we don't routinely check CMV PCR. We only check if there is a clinical concern, like if they have like unexplained cytopenias or any concern for CMV colitis, then we will check it. Some centers like Mount Sinai, in New York, they have checked it routinely, especially during the clinical trial, and they have shown that the risk of CMV reactivation is actually quite high. But a vast majority of them are just viral reactivation in the blood without a clinical like end organ damage. So we don't routinely check it unless there is a clinical concern for it. But we if patients are sick and it's unexplained, then we do have that in the differential diagnosis with CMV, adeno, and things like that.
Thank you
I
very
think,
much. I will have to cut it
yeah,
short,
ma'am,
Harit,
sure.
because we need to give Sumit enough time. So Dr. Sumit, you can take the eagle eye competition ahead.
There is one more question which we can answer, just papilloma vaccine to men. You can just
Um,
answer on online. Just answer online. Yeah.
Shall I share?
Yeah, Sumit, you can go ahead.
Okay. Is my screen visible, sir?
Not yet. Yes.
Okay. So the Eagle Eye competition article for November 2024 was teclistamab and glaf for refractory AL amyloidosis, a multinational retrospective case series. This was from the French group of experts. And I wanted to ask this, but I forgot about Dr. Rajshekhar's opinion on teclistamab and AL amyloid. We probably discuss this after the end of general scan. So just to brief an overview to people who are new about the process of the journal scan and the Eagle Eye competition. Uh, an article is selected or recently published, and a commentary is invited of 175 words before a deadline. Anybody who's interested can send this commentary, and whosoever wins this presents gets an opportunity to present this in front of a very good audience, along with a lifetime image membership. The intention is that the faculty in India, as well as students in India, should read the latest articles. They should learn the art of critical appraisal, refine the art of scanning an article, which will give rise to more letter to editors from India and get an opportunity to present from a very good audience. So multiple variables are considered while analyzing this. which include the title, the abstract representation, the author's assumptions, the critical word limit, which is very important. There must be some errors in the author's interpretations and facts. Some ideas may be over or underemphasized. The approaches, the statistical methods, the references, ultimately boiling down to a final score. So before I announce the name of the winner, I'm very grateful to our reviewers for this month, which is Dr. Reena Nair Madam and Dr. Melinkari sir. The winner is Dr. Deep Gala. This is the second time that he has won, to the best of my knowledge. He is a DM resident in clinical hematology at SGPGA Lucknow. Congratulations, Deep. You missed it narrowly by last time, but you made it this time. So I give it over to the Mice Ideas team for displaying his recorded commentary. Priyanshi, Nirav, you can please display the recorded commentary.
Good evening, respected teachers and colleagues. I would like to thank Image Group for this opportunity to present today's journal scan. Today's article is a letter to editor by Forgard and group demonstrating the utility of teclistamab in relapsed refractory AL amyloidosis. Current treatment of newly diagnosed AL amyloidosis focuses on bortezomib and daratumumab-based regimens or high-dose melphalan with stem cell transplantation. Andromeda trial demonstrated the utility of daratumumab with hematologic CR attained in 53.3% patients with daratumumab-based treatment compared to only 18.1% patients with VCD. Limited treatment options exist for relapsed refractory disease. Venetoclax can be used for translocation 11-14. Anti-BCMA therapy with belantamab mafodotin has also been tried for relapsed AL amyloidosis. Coming to teclistamab is a bispecific T-cell engager. It engages CD3 on T-cell with BCMA on plasma cell, thereby facilitating killing of the plasma cell by T-cell. It has been recently approved for treatment of relapsed refractory multiple myeloma based on the Majestic trial. It showed overall response rates of 63% and MRD negativity rates of 26.7% for relapsed refractory multiple myeloma. The current study is a retrospective analysis of 17 patients with relapsed refractory AL amyloidosis treated with teclistamab between July 2022 and August 2023 across 10 European centers. The dosing for teclistamab, a step-up dosing was used. Subcutaneous administration was used. On day 1, the patients were given 0.06 mg per kg, followed by 0.3 mg per kg on day 4, followed by 1.5 mg per kg on day 8, and 1.5 mg per kg weekly thereafter. Standard response criteria were used for disease assessment. A CR was defined as a normal free light chain level with a normal kappa lambda ratio and a negative serum and urine immunofixation. VGPR was defined as a DFLC of less than 40 and any 50% reduction in DFLC was defined as PR. Coming on to patient characteristics, the median age of the cohort was 67 years. Median bone marrow plasma cell percentage at diagnosis was 21%. 94% had cardiac involvement, 59% had kidney involvement. It is important to note that 59% patients had a concomitant multiple myeloma in this study. Median number of prior lines of therapy received was 4. 94% were triple exposed, 71% patients were triple refractory, and 18% were penta exposed, while 18% patients were also penta refractory. Coming to the response rates with teclistamab, this is the swimmer's plot showcasing the longitudinal follow-up of the patients. Median number of cycles received by patients were 3. VGPR or better was seen in 15 out of the 17 patients. A CR or a better response occurred in 7 patients. Involved free light chain level of less than 10 was seen in 13 patients. Median time to best hematologic response was 28 days. 29% also demonstrated organ response. And at a median follow-up of 3 months, there was no hematologic relapse. 2 deaths occurred, 1 occurred due to disease progression and 1 from infection. With teclistamab therapy, 9 patients developed CRS, but all were grade 1. Out of these 9, 2 received tocilizumab for CRS. Grade 3 to 5 bacterial infections were seen in 5 patients, with 1 death. Viral infections occurred in 5 patients, that is 29%. Treatment discontinuation was seen in 2 patients due to adverse events, and 2 patients discontinued treatment due to CR. Comparing the current study with the previous case series by Chakraborty et al. In patients with relapsed refractory multiple myeloma, a similar response rates, that is the 88% response VGPR or better, was seen in the current study compared to 100% in the previous study by Chakraborty et al. A median time to response in the current study was 28 days compared to 18 days. CRS was seen in 9 out of the 17 patients in the current study compared to 4 out of 7 patients in the previous case series. Bacterial infections were seen in 5 out of 17 patients in the current study compared to 2 out of 7 patients in the previous case series. To summarize, teclistamab is easy to administer, high response rates can be achieved even in heavily pretreated patients, and responses are deep and they can be seen as early as 14 days, with a median time to response of 1 month. However, current study has its own limitations, being retrospective in nature with a modest number of patients. The current study has a very short follow-up, and there are longer follow-up are required for proper organ assessment. This current study includes a large number of patients with a concomitant multiple myeloma. 10 out of the 17 patients had a concomitant multiple myeloma. So, utility of teclistamab in AL amyloidosis merits further exploration in patients with a low plasma cell burden, that is, excluding patients with concomitant multiple myeloma, like in Andromeda trial. Apart from CRS and ICANS, high rates of infection with teclistamab will continue to pose a problem for our patients, and there is requirement of patient support programs to eliminate the cost barrier and provide continuous monitoring and care. Thank you.
Thank you, Deep, for a nice presentation. So we went through the recorded commentary. The journal scan article for the next month, that is December 2024. The theme for December 2024 is translocation 1114 plasma cell neoplasms. And the journal scan article is on lab-based. A primary plasma cell leukemia displaying translocation 1114 have specific genomic, transcriptional, and clinical features, again pioneered by the French group, published in Blood in 2022. A special announcement is for the Indian Myeloma Congress in 2025, and this is for the National Myeloma Quiz, which typically happens in the Indian Myeloma Congress. The prelims are slotted for January 10th, 2025 in the early morning, and the top 5 teams will make on to the finals for Sunday in the morning. Those who wish to participate can participate in a team of 2, those who are postdoctoral students or those who are doing their DM in medical oncology, hematology, or DRNB in hematology or medical oncology are welcome to participate, and there'll be some exciting prizes for sure. And I'm grateful to Johnson & Johnson and Dr. Reddy's for supporting this webinar by their educational grant. Hereby I call upon Dr. Nitin Yashas, who is a very versatile and amazing quizmaster. Over to him.
Right. I just would like to thank Dr. Uday, Dr. Sumit, and of course all the members of Image for providing this opportunity. This is a very, very interesting journal club and journal scans today, which I have the opportunity to do a quiz on. I hope that all the participants listen to it, because if you've listened to it, you will be able to crack this quiz. Can I have the organizers share the PowerPoint?
Sure, sir. 1 second.
Right. Next slide. Right. I think a very pretty standard rules. You have 5 questions. It's a single answer correct MCQs. And as always, we are in the era of T20. India may be in the lead for the World Test Championship, but it's T20 time. So fastest people win it. There's a timer that is going to be displayed in the platform that you're entering the question. And at the end of the quiz, the individual or the participant who has answered more accurately and in a quick manner wins the prize. I think we should be good to go. So if all of you are ready, we'll just wait for 20 seconds and then we will start with the first question after 20 seconds.
Nitin, is this for students only or for us also?
Sir, students only.
Okay.
So those who are any junior faculty or anybody who is there as an audience other than the panelists can definitely participate.
Okay.
Right. So the first question, a little bit of trivia to start off with. The term amyloidosis is derived from the Latin word amylum, meaning what? Is it A, proteinaceous? Is it B, gelatinaceous? Is it C, starch-like? Or is it D, lardaceous? What does the term amyloidosis actually come from? Very interesting history. If you read about how Virchow was one of the first ones to actually describe it, though there were some case reports before that.
Is it timer?
Right. Moving
So
on to
we are counting the we have the timer, so we'll do next.
Okay.
Right.
Okay.
Right. Which of the following factors was a predictor of either increased or decreased? Please note, either increased or decreased risk of infectious complications with teclistamab. Was it baseline hypogammaglobulinemia? Was it a baseline lymphopenia? Did prior lines of therapy make a difference, or was it IVIG prophylaxis? Which of these was associated with a risk? So 30 seconds per question. Right. So this comes from the journal Scan article, the Journal Club article. Which of the following was not different? Keep in mind, was not different in comparison between the real world study in the article and the landmark Majestic trial. Was it the presence of extramedullary disease? Was it B, the objective response rate? Was it a high risk cytogenetic profile, or was it the median follow-up? Was not different. A lot of discussions happened about this study, some fantastic insights by our seniors and professors, but what was not different? Right. So we move on to the last two questions from the journal Scan article. And which of the following statements is true with response to teclistamab in heavily treated amyloidosis? The earliest response noted was in 14 days. The median time to best hematological response was 45 days. Less than 60% patients achieved a VGPR and 60% achieved an organ response. Which of the following statements is true? And the last question, and we always have to be mindful about the side effects and the complication profile whenever we are using teclistamab, as our panelists discussed today. So which of the following again is not true? 50% developed CRS, 50% developed a serious grade 3, grade 5 bacterial infection, about 30% developed a viral infection. Treatment discontinuation happened in 25% either for adverse events or because they were in CR. Which of the following is not true? Right, with that, we come to the end of it. From T20, we have moved to almost the T10 era. 5 MCQ questions, and we are done with the quiz. And now we will move to the answers. Our respected panelists can also sort of now unmute themselves and speak if they want to get into the fun without looking at the screen. Right, the first question, the answer being, we can move to the answer. Next slide. Right, the term amyloidosis is derived from the Latin word amylum, meaning starch-like, though of course there are a lot of description of it being lardaceous, proteinaceous at times. Because the initial specimens which Virchow and some of the pioneers did reacted with iodine blue, they thought that it was a starch-like material, and therefore from amylum meaning starch, we have amyloidosis. So C, starch-like, is the correct answer. Question number 2. Right, which of the following factors was a predictor? And I think this was discussed. The one factor which was very, very much protective and decreased the risk of infectious complications was IVIG prophylaxis. The only other factor that was associated with an increased risk was a previous history of infections with teclistamab. None of the other factors, be it prior lines of therapy, baseline lymphopenia, or baseline hypogammaglobulinemia, was significantly associated with infectious complications. So big learning point for all the residents and anyone watching this, that on teclistamab, usage of IVIG prophylaxis is necessary to avoid the risk of infectious complications, particularly in our setting. Question number 3. Right. So, which of the following was not different? And the answer was the objective response rate. Both the landmark trial and the real world study showed close to 62% objective response rate. And this is very remarkable because the real world study had more of extramedullary disease. It had more of high risk cytogenetic profile. And again, as discussed earlier, the median follow-up was shorter as compared to the Majestic trial, which almost had a 22 months follow-up. So the one thing which was not different was the objective response rate, which was around 62%. All right, the penultimate question, question number 4. Right, which of the following statements is true? And yes, usage of teclistamab.
Within one question. Go back to the previous one.
Yeah.
What
organizers,
was not different? The median time was only 3.5 months over here, no, in the study, and otherwise it was 22 months in the Majestic study. So isn't that the one which is different?
That's what it said. So you're asking what was not different.
Oh, I'm so
that is what happens even to participants. So that's where the googlies come in.
Sorry.
Right, no problem. Right. I'm happy that my questions were a little tough. Right. So which of the following statements is true with response to teclistamab? And yes, the earliest response was noted as early as 2 weeks. The median time to best hematological response was actually not 45 days. It was 28 days or close to a month. Almost 80% patients achieved a VGPR. And again, it was around 30% of patients who achieved an organ response. It was around 4 cardiac and another patient cardiac with kidney. So again, a remarkable thing about the molecule is that in heavily treated amyloidosis, we are seeing that in certain patients, the earliest response can happen as early as 2 weeks with a median time within a month, right? So I think the last question, I'm not sure who is in the lead and who is not, but I hope you got this correct. And again, very important to be aware about the complications, and 50% is actually high. And again, when you have 50% high, not many would be willing to use such a drug. It was around 30% who developed a serious grade 3, grade 5 bacterial infection. And again, it was 30% who developed a viral infection. 50% developed CRS, and wonderful commentary given about the identification of the CRS as well. Very interestingly, treatment discontinuation happened in 2 patients because they were in CR and it was not continued as such. And in the other 2 patients, making it to a total of 25% treatment discontinuation happened for the adverse events. So, right, we come to the end of it, and it's like I should do a sign like this, like Dhoni review system or the DRS, to the organizers to tabulate the scores and give us who the winners are. Once again, heartfelt gratitude to Dr. Uday, Dr. Sumit, and the entire organizers of Image for giving me this opportunity for such interesting papers. Thank you.
So our winner is Dr. Deep Ajay Gala from Lucknow, and he's from Sanjay Gandhi Postgraduate Institute of Medical Sciences.
Today is Dr. Gala's day. Congratulations.
Right. Congratulations to the winner and their professors, of course.
So with that, we come to an end of a very interesting session. I really want all of you to go on to the Image website. The IMC 2025 is uploaded. We have the quiz, we have question answer session for patients, we have abstracts, and the deadline is 10th. And we look forward to all of you coming here. And of course, Dr. Raj, we'll miss you, but hopefully at some point of time when you are in Calcutta, you're welcome to come over to our institute. So
Absolutely.
Uday and Pankaj, the last word to both of you.
Raj wants to make any comments?
No, I think it was great. I completely echo Dr. Samir's comment that, we really need long follow-up in the real world studies. And hopefully in the next few years, we'll get, especially in the Majestic 1 trial, we have now almost median of 2 years of follow-up. And I think it would be good to see whether in the real world, we are also seeing a similar kind of durability of response, because these patients were much heavily pre-treated with a high tumor burden. So definitely more to come, and very exciting space.
Right. And
so if Pankaj permits, a quick announcement. So we are actually so thankful to Nitin, who is conducting the quiz for the first time for the Image Journal Clubs. Otherwise, he has been conducting it for last 2 years for the annual conference. He is one of the most sought after quiz master in the South. So thanks, Nitin, for being part of this. We want a long association with you. The second thing is we from Image are tabulating the complete bi-specific data from all across the country. So we are getting the information, and we have requested all the people who have used it. So any of you who are using Techlist map, if the data can be shared with Image, we are tabulating it at one place, and thereafter one of the people, whoever has the highest number, can put it together and write it forward. But we at Image are trying to summarize the experiences from Indian subcontinent, primarily because we perceive that we have higher infection rates and the patients would behave differently in this subcontinent. So for that particular purpose, we are trying to do this exercise. And lastly, we are coming up with 3 consensus guidelines. So all those who are Image members, please choose the guidelines you want to be part of. And for those who are not yet members, we request you to become an Image Life member to be part of the consensus guidelines, which are going to be released during the national conference, the most sought after conference in Calcutta, which is going to be a big conference as far as organization and as far as the expectations are concerned. So we like to see you all there. So with that, I hand it over to the president for his final comments, please.
Thanks, Uday. Again, it's my duty to thank Raj, who has, I think it's early morning, Raj. What is the time
Yeah,
there?
it's now 8 o'clock. It's okay. Yeah,
Okay,
not that
it's
early, but yeah, thank you very much
okay.
for the opportunity to come
Yeah,
on.
so we would like to, see you in more journal clubs as well as in the Image conference. So we are thankful to you. We are thankful to Sameer for becoming the national expert, Dr. Reena Nair for moderating it, and we welcome our new entrant, Dr. Nitin, for holding the quiz. And hopefully, we would have a long association. Uh, Colonel Uday has already told you about 3 guidelines, and these are newly diagnosed multiple myeloma, relapsed refractory multiple myeloma, and infections in multiple myeloma. So it is by a Delphi survey. So the first survey is gone for infection as well as for newly diagnosed. And for relapsed refractory, I think it would be on its way, and we hopefully we would be able to reach a consensus on these guidelines, and we would be able to release these guidelines during the Kolkata conference. For these guidelines, not only India, we are also roping in myeloma physicians from Sri Lanka, Nepal, Pakistan, Bangladesh, and Myanmar, and Bhutan, and Maldives. So it would be kind of a mix of South Asian countries, South Asian and Southeast countries. So hopefully we will have more of these, and we would all urge all the youngsters to be part of Image and participate in the awareness, creating awareness about the myeloma as well as improving the outcome of myeloma patient. With that, I thank you very much for your kind attention, and we'll see you in the next Journal Club, which is going to be held on 26th of December, as announced by Dr. Sumit. And again, I missed Sumit, thanking Sumit. So thanks to Sumit also, and Urmi also. Yeah. And to the Mice Ideas. Thank you so much. Take care. Bye bye.
And to our sponsors for the day.
Yes. Bye bye.